Hello and welcome back to Unacademy. So let's crack NEET PG. Myself Dr. Muskan Chaudhary, and we'll take a session, rapid session on the mycology. All right, it will be a fast rapid session, and we'll cover the images as well in today's this session because images are very important from the mycology. Therefore, I was taken in the session as well. And we'll do cover the image based session later in the coming days. Now, starting with Unacademy India, it is the India's largest learning platform where you get access to both the live and the recorded sessions. Learning from the India's topmost educator for any medical examination, and you can personalize your learning experience with your favorite educator. Compete in the live T&D's test of preparation with the highly competitive quizzes and the study on the device anywhere and everywhere from India and all over the world. Whenever you travel and you're doing the JRship or working in the hospitals and find it difficult to cope up with the live classes, you can just take the watch the recorded sessions with approx 25,000 of the MCQs, which are more than enough and sufficient from every detailed topic and every topic that is has the probability to be asked in the examination. These printed and digital notes are provided. Under iconic subscriptions, the Unacademy has come together with the Prep Ladder, where you get access to the clinical and the integrated essentials, video lectures, and the QBanks and the rapid revision, and the Treasure 2021 Dream the Prep Ladder with well-structured live batches, recorded sessions, two banks of around 25,000 views, competitive T&Ds, and the printed and the digital notes. For NEET PG subscriptions category under plus, it will cost you around 36,000 for 2 years, that is 1,500 per month. For 18 months, it will be around 1,625, and for 36 months, it will be around 1,250. For iconic subscriptions, it will be around 2,438 per month, 1,875 and 2,875 per month for 18 months and 36 months respectively. Please do use my code, that is Muskan 10, to get 10% discount. Raise a hand feature, something new, something unique feature from the Unacademy where you can raise the hand in the live class, and the educators will drive engagement with one-on-one interaction with the aspirants, and you get easy access to solve your doubts and the basics during the live session just by raising the hand. So 25,000 MCQs on the latest examination patterns, including the detailed explanation. Special class features include the interactive classes. You can do the polling for the learner so that you get the environment same as the examination. Raise a hand, that is talk to your educator. Never miss a class because you will get the notification for the same. And the lecture notes, download the lecture notes from the Telegram and the Unacademy app anywhere and anytime along with the Unacademy. Yeah, hello everyone. Chalo, with 24 month subscriptions, 2 month is totally free, and with 12 month subscriptions, 2 month is totally free. With 6 month subscriptions, 1 month is totally free, and you my code, that is to get 10% discount to get the 10% the discount. So we'll start with the okay. Okay, so starting with the fungus, all the important points we'll cover. All the important points we'll cover. Now, it is both unicellular or multicellular eukaryote. And what we need to remember is that they contain, very important, they contain chitin in the cell wall. And most important point, other important point, that in the cytoplasmic membrane, they have what? A role. They are mainly existing as saprophytes in nature, and occasionally becomes pathogenic to the okay, pathogenic to the humans. Now we'll come to the points that are very important. That one is that they have the chitin in the cell wall. They have what chitin in the cell wall, on the basis of which several stains are present which bind to the chitin and helps in the identification of the fungus. And they have what ergosterol in the cell membrane, and they are mainly saprophytic eukaryotes. Now this is what. Okay, so that is what having what chitin in the cell wall. Now we'll come to the morphological classification. We'll come to the morphological classification of the fungus. Okay, we'll come to the morphological classification of the fungus. Now first is the yeast form. We have yeast like form. We have what moles, and what else we have? We have dimorphic fungus. Okay, so yeast form and yeast like form, that is yeast like form, we are having not the true hypha, we are having the pseudo hyphae. That is what Candida. Or moles, they exist as the hyphae, and yeast that is in the bud form. What are the examples of the yeast? Cryptococcus, Saccharomyces. Now moles, they exist as a hyphae, and they are further of the two types, that is one is what aseptate hyphae and the septate hyphae. Dimorphic fungus, we'll read in the detail the mnemonic for the dimorphic fungus, because that is dimorphic, that is having the two morphological forms, that is having two morphological forms. One is what septate, one is what hyphae form, that is a mole form, and another is what yeast form. Another is what yeast form, and they have two forms, that is one is what mole form and another is what yeast form. Yeast form will be present at what temperature? At 37 degrees Celsius temperature, and mold form 25 to 26 degree Celsius temperature. Now remember example that is of the yeast form, yeast like form, that is the Candida. And dimorphic fungus, we have the mnemonic for the dimorphic fungus, that is HBSC, produce pencil. Okay, we have the mnemonic for the dimorphic fungus, and very important that question, dimorphic fungus. Examples, that is H for what? Histoplasma capsulatum. And the interesting part is that it is not capsulated. It is a misnomer that it is not capsulated. Now, B for blastomycosis, S for Sporothrix shanki, C for coccidiomycosis, and what is penicillin marfinic. Okay, so this mnemonic is where this Dimorphofungus examples are very important. That Dimorphofungus having the two morphological forms. One is the mole form and one other is the yeast form. Yeast form is at what 37 degrees Celsius temperature, and these are the examples of what examples of the dimorphic fungus. Now we saw the morphological classification in the yeast like Dimorphofungus and the mole form. Now Dimorphofungus, that is the mnemonic we have already covered, HBSA produce pencil. Now coming to reproduction in the fungus, on the basis of the classification of the fungus, on the basis of reproduction, we have vegetative, asexual, and the sexual. I'll tell you the what we need to just remember the most important one. Now this is the list. You can read it in the spare time. Number one point that we need to cover is that when we talk about the reproduction and when we talk about the sexual state which is not identified in the fungus is which one is what is deuteromy- deuteromycetes or fungal imperfecta. Okay, deuteromycetes or the fungal imperfecta, their sexual state has not been identified yet, and they are what they are most pathogenic fungus. Okay, they are what they are most pathogenic fungus, and their sexual state has not yet been identified. Other than that, we have the sexual spores like ascospores in ascomycetes, and the basidospores and the basidomycetes, zygospores in the zygomycetes. Coming to the important stains that we need to remember, these are general stains that we use for the fungus. These are general stains that we use for the fungus. As I already told you, the presence of the presence of the chitin in the cell wall is an important component because many stains they bind with the chitin and help us in the recognition of the fungus. Now, the best fungal stain is which one? It is what Gomoris methylamine stain. Yeah, that is the GMS, that is Gomoris. Okay, so now first we'll see what first we'll see what in the stain that calcofluor white, it binds with what? It binds with chitin in the cell wall, and the calcofluor white is seen under the fluorescence. We'll see the image under the fluorescence. We see for the binding of the stain with that of the chitin. Other than this, we use the HNE stain and lactophenol stain, the GMS stain, and the PS stain. Indian stain is very important. We see for the Cryptococcus. Why? Because they are having what? They are what? Only fungus that is capsulated is what? Cryptococcus neoforms. That is the only fungus that is what? Capsulated. That is Cryptococcus neoforms. Other than this, we have the mucicarmine stain and the Fontana mason stain to detect the melanin pigment in the Cryptococcus again. Okay, so Fontana mason stain to detect the melanin again in the cell wall of the Cryptococcus. India ink is again used for the Cryptococcus, and the mucicarmine stain, that is to stain the mucopolysaccharide in the Cryptococcus and Blastomycosis. So this is what Gomoris grocot methamine silver staining. That is, it is the best fungal stain. It is the best fungal stain. That is Gomoris methamine stains or grocots methanamine stain. And the Gomoris methamine stain, how does it work? That it binds, the stain binds with the cell wall, the chitin cell wall of the fungus. This is the stain that is what calcofluor white fluorescent stain, and under the fluorescence it also binds with the chitin cell wall, and under the fluorescence the blue white fluorescent we can easily differentiate. Now, next we covered about the Elshin blue stain, and we saw that it binds with what? Acid mucopolysaccharide. Acid mucopolysaccharide. Now coming to the culture media, now stains, remember the name of the stain, the GMS is the best fungal stain. Other than this, we are having the Indiana ink stain and the Elshin blue stain and this PAS stain and the HNE stain. Now coming to the culture media. For the cultivation, now very important, we use saburoid dextrose agar. We use saburoid dextrose agar with the chloroamphenicol or the gentamicin with gentamicin or the chloramphenicol or the cyclohexidine. What is the reason we are using along with the antibiotics? So that we can easily grow the fungal by inhibiting the bacteria along with that. So we are using for the culture media, we are using the saburoids dextrose agar with the antibiotics. Other than this, this is the general culture media that we use is SDA. Other than this, we are using brain heart infusion agar. We are using what? Brain heart infusion agar along with the 50% of the blood. Now, brain heart infusion agar, it is mainly used for dimorphic fungus. Dimorphic fungus. All right. So this is what SDA agar. This is Sabror dextrose agar. You can see the Candida and Trichophyton growth in the SDA, and other culture media we are using is what EHIA, that is a brain heart infusion agar for the dimorphic fungus. Now we'll come to the superficial subcutaneous dimorphic fungus and the deep fungal infections. Now first we'll see about the superficial mycosis. Superficial mycosis. So we'll see for the superficial mycosis. What is this? Which superficial mycosis is it? We'll read about the Tinea versicolor, we read about the Tinea nigra, then Pedra and Dermatophytes. This is Tinea versicolor or Pityriasis versicolor, alright, or the Maliseae furfur. Just all right, so where were we? We went superficial mycosis, that is a superficial layer of the epidermis is involved, and it is a tinea versicolor, pityriasis versicolor, or the Maliseae furfur, and we see what hypo or hyperpigmented macules or erythematous patches surrounded by the scales. Now, for the diagnosis, we can see in this that for the diagnosis, we take the skin scrapings and under 10% of the KOH mount, we see what appearance? We see the spaghetti and meatball appearance. Spaghetti or the meatball appearance. Okay? the spaghetti or the similar to that of the spaghetti or the meatball appearance, that is in the superficial mycosis tinea versicolor. Other than this, using the 10% of the KOH, we can also see under the wood lamp, and under the wood lamp we'll also see that image. Under the wood lamp we see the golden yellow appearance under the wood lamp. And under the SDA we see what's fried egg colonies, very important, fried egg colonies. So for the tinea versicolor, for the lab diagnosis, under the 10% of the QH mount, we are seeing the spaghetti and the meatball appearance. Under the wood slime, we see the golden yellow appearance, and the SDA is what giving the fried egg colonies. The fried egg colonies under the SDA, we are getting what? The fried egg colonies and the spaghetti and the meatball appearance under the 10% of the KOH mount. So culture on the SDA with olive oil, fried egg colonies, and direct microscopy, budding yeast-like cells, and short angular hyphae forms. So that is the spaghetti and the meatball appearance. Spaghetti is what yeast-like cells, and the hyphal form, that is the meatball appearance, typically seen in the Pityriasis versicolor. Now this is under the wood slam, that is what giving the golden yellow appearance. Now, next we come to what? Next superficial mycosis that we come to what is what? Pedra. Is what? Pedra. That is either it is the superficial infection of the hair nodules, and it is of two types, that is black pedra or white pedra. Okay. Now, for the tinea versicolor, the treatment we give is what? Terbinafine cream, terbinafine cream, and selenium sulfide. Okay. Selenium sulfide and terbinafine cream. Now, Petra is of two types, that is the in superficial infection of the hair nodules, that is the black and the white. Black and the white. The black Petra is caused by what? Petra hortic, and the white Petra, that is caused by what? Trichosporum bacilli. Okay. So it is the formation of the nodules on the hair, and you can see the black nodules. The black nodules, that is the black Petra caused by the Petra horte, and this is the white nodules, that is caused by the white Trichosporum bacilli. And they are what along the hair shaft, you can see they are along the hair shaft. And what is the most common site for that of the white pedra and the black pedra? For the white pedra, the most common site is what? Pubic hairs. And for the black pedra, the most common site is what? Scalp hair. Scalp hairs. Okay. Okay. Now coming next to the dermatophytes, coming next we have covered the tinea versicolor, we have the pedra, white and the black. The white, the most common site is pubic hair, and white is due to mainly what? Trichosporum vigili. Black is most common site is scalp hair, and it is due to the pedra horte, and it is what? It is a superficial infection and causes the hair nodules. Now moving to next, that is the dermatophytes. Moving to next, that is the dermatophytes. Dermatophytes, that is also known as Tinea, Justinia, or the ringworm. Okay. Now dermatophytes, they utilize what? They utilize the keratin as the source of the nutrition. Okay. Dermatophytes or the tinea or the ringworm that utilize the keratin as a nutrition, and they are also what? Superficial mycosis. And we have three types of the dermatophytes, that is what? Trichophyton microsporum, and what else? Epidermophyton. Okay. Trichophyton microsporum and the epidermophyton. Skin will be involved in all the three. Now, hair and the nails in the trichophyton, hair in the microsporum, and epidermophyton, that is nails. Skin plus hair plus nails, and skin plus nails. Now, how to remember the microsporum? Skin is involved in all the three. Microsporum, you write this M, and this is H. Okay, so hair is involved in the microsporum, and the epidermophyton, nails are involved. And trichophyton, both the involved hair and the nails. Now, coming to the disease that are caused by them. Now, most common. Now, first we'll see according to the reservoir, the classification. That is what? That is whether they are what? Anthrophilic. Man is the reservoir. That is Tinea rubrum, Tinea filicium, Tinea flocculosa. Now, Tinea rubrum is responsible. It is the most common tinea, and it is causing most common onychomycosis. Okay, and the Volicium, that is causing most common, second most common Favus, and the most common tinea that is responsible for the Favus is what? Colony. Next, we have the zoophilic, that is animals are the reservoir, and we have Microsporum canis, we have Tinea equina, we have Tinea mentophytes, and we have Tinea verrucosum. That is most common cause for the Kirion. Now, remember most common tinea is what? Tinea rubrum. That is the responsible for the onychomycosis. Then we have for the when we have for in the zoophilic, that is the most common Kirion responsible, that is a Tinea verrucosum. Then we have the geophilic, that is what? That is soil is the reservoir. Soil is the reservoir. And we have what? Tinea gypsum, Tinea ageloi. Now we'll come to the disease that are caused by them. Disease that are caused by them. Also, you will read in the dermat as well, but we'll also cover some important things here as well in the tinea. Now, coming to disease types, we have seen already trichophyton, epidermophyton, and the microsporum, and what are the sites they are involving. Now, tinea capitis. Tinea capitis, that is involving what? Scalp. Next, we have tinea barbe. that is involving what? Beard. Next we have tinea unguingum, that is involving what? Nail, paws. Then we have tinea menum, that is involving what? Hand. Then we have tinea puris, that is involving what? Groin. Then we have tinea pedis, that is involving what? Foot. Now tinea cruris, that is involving what? Groin, that is also known as the tinea or jack itch or the jack itch. Tinea pedis, that is involving the foot, that is the also known as athlete's foot, seen mainly in them, athlete's foot. Then we have the tinea corporis, that is involving the non-hairy region of body, that is involving what? Non-hairy region of the body. So we are having a tinea capitis, scalp, tinea barbara, that is the beard, tinea inguinum, that is the nail fons, manum, that is the hand, cruris, groin, that is the obi or the jack itch, that is the jack itch, pedis, that is the foot, athlete's foot, and the tinea corpus, that is the non-hairy region of the body. So this is the dermatophytes that we are reading, and it is also known, we have seen that tinea or the ringworm, and all the tinea we have read, and we'll see some presentation. This is tinea pedis. So tinea favors, that is what? Perifollicular erythema on the scalp, which progress to characteristic finding, that is a cup-shaped yellow crust, that is what? Scula. That is what? Scula. Now coming to some important tinea, that is the Trichophyton, Mentagr- Mentagrophytes, Trichophyton, Mentagrophytes. Now, Trichophyton, rubrum. For that we do what? We do the hair perforation test. Again important, hair perforation test, urease test, which is positive in what? Which is positive in the Trichophyton, Mentagrophytes. And we get what? Infected hair with moist conditions. Hair perforation test will be positive. Tinea capitis, tinea capitis. And what are the types of the tinea capitis? One is what? Favus, and one is Virion. You might read in the dermat. In the favus, that is what? Dense crust formation. Dense crust formation where on the scalp. That is on the favus. In the chirion, it is a painful boggy swelling. Painful boggy swelling where? Over the scalp. So in the tinea capitis, that is involving of the scalp, it is further of two types. One is the favus, another is the chirion. Favus, there is crust formation. In the favus, there is what? Crust formation on the scalp, and the chirion, that is what? Swelling over the scalp. Dense, this painful boggy swelling over the scalp. Now, favus is mainly caused by the Trichophyton Tonlini. As I already told you, the most common organism for causing the fungus causing the favors is what? This Tonlini, that is a Trichophyton Tonlini. And for the chirion, it is what? Trichophyton, that 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 is what? variocosum, and Trichophyton pentagrophytes. We already covered variocosum, that is the most common fungal infection causing the yawn and the Cholerae for the favors. Now before coming to the next image, we'll see the lab diagnosis. We'll see the on the basis of the difference on the trichophyton, epidermophyton, and the microsporum. Trichophyton, epidermophyton, and the microsporum. Now, when we talk about the shape of the macroconidia, then number of macroconidia, and then microconidia. Macroconidia in the trichophyton, they are what? Pencil shaped. Trichophyton, this involve both the skin plus hair plus nail. Epidermophyte in the skin plus nail and skin plus hair. That is a pencil shaped macroconidia. In the epidermophyton, it is cup shaped, and in the boat shaped or the spindle shaped. We'll see the shape. Now here the microconidia are few and there are many. Microconidia here many, here few, but absent in the epidermophyton. So microconidia absent in the epidermophyton and few macroconidia in the trichophyton with the pencil shape, club shape, and the boat shape. So favors, we have seen the favors and the chirion. Now, Tinea capitis is also classified according to how the fungus invades the hair shaft, whether it is ectotherix infection or the endotherix. Now, in the ectotherix, the fungal branches, the hyphae and the spore covers outside the hairs. Spore covers the outside the hair in case of the ectotherix, and the most common is what? Is what? This is canis and the odoni. Now, in the case of the endothrix, it is what the hair shaft is filled with. Hair shaft is filled with what? Fungal branches and the fungal spores. For the chaos preparation also in the ectothrix and endothrix will see the same, that it is what it is. The left one is what the ectothrix, that is the you can see the spores outside the hair shaft, and in this you can see the spores and the hyphae inside the hair shaft. This is what endothrix. Now Trichophyton, microsporum, and the epidermophyton. We have seen for the trichophyton, microsporum, and the epidermophyton. For the trichosporum, we have seen they are what? They are pencil shaped. They are pencil shaped macroconidia. The microscope, they are boat shaped or they are what? Spindle shaped, and the club shaped in the epidermophyton, and club shaped in the epidermophyton. Epidermophyton produce only the macroconidia, and they are having what? No microconidia. They are having what? No microconidia. Microsporum, both macro and the rough wall macroconidia, and trichophyton, that is the species, a smooth wall, and they are having macroconidia. The trichophyton. Now we'll come to the subcutaneous mycosis. Subcutaneous mycosis, and we'll read about the mycetoma, chromoblastomycosis, sporotrichosis, rhinosporotius, and the pyohyomycosis. Okay, first we'll see in the subcutaneous mycosis is the mycetoma. mycetoma or the Madura foot. Mycetoma or the Madura foot. And in this, we read about two. One is the actinomycetoma and eumycetoma. We'll come to some of the difference between the actinomycetoma and the eumycetoma. That actinomycetoma, we've already seen that they are what they are, bacterial in origin, and eumycetoma, they are what, fungal in origin. Another important difference that is they have multiple sinus discharge with the swelling in the actinomycetoma, and they have the single sinus discharge with the swelling generally. Then we have the purulent discharge in the actinomycetoma, and here we have the serous discharge. Another important point is that the granules are white to yellow in the actinomycetoma, and here the granules are generally what, black. Black granules and white granules. We have yellow to red granules in the actinomycetoma. So actinomycetoma, it is what one, it is that it is strictly an aerobic condition, this aerobic and the bacterial origin with multiple discharging swelling with purulent discharge and yellow to red color granules, and crush granules are seen under the microbes. Here we see what? Here we see the crushed granules are seen under the microbes more than 2 micrometer. Here less than 2 micrometer. So some basic difference between actinomycetoma and eumycetoma. One is bacterial and the fungal in origin with multiple discharging sinus, purulent discharge, and yellow to red color granules. Yellow that is seen in the actinomycetoma, yellow color granules that is seen in what? Actinomadura. Madura, and what else? Nocardia. And red granules that are seen where? Actinomadura palatree. Okay, so yellow granules in the actinomycetoma that is seen where? In actinomadura and nocardia pari. And red granules where? Red granules we see the actinomadura palatree. So this is for the actinomycetoma. Now about eumycetoma, the black granules are seen where? In the Madurella grisa and Madurella mycete. And the white granules, acrimonium and Soelistria. Alright, we see the black to white granules. Now next we come to the subcutaneous mycosis. That is what? That is the Chromoblastomycosis. Very important that it is what? It is a dermatitious fungus. Alright, and it involves the, because it is subcutaneous, therefore it will involve both the skin and the subcutaneous tissues. Important point is that we for the sclerotic bodies or the medullary bodies, or the copper penny bodies or the reform cells. They all are same. So in the chromoblastomycosis, you can see the copper colored bodies. These are what the medullary bodies, muriform cells, copper penny bodies, or the sclerotic bodies, or the sclerotic bodies. Now coming next to, this is the most important in the chromoblastomycosis. Now, and the treatment of the chromoblastomycosis is difficult, and it is generally the surgical treatment. So remember, we get what the sclerotic bodies, medullary bodies on the this tissue biopsy, and the muriform cells or the muriform cells. Now, next we come to rhinosporidiosis. Rhinosporidiosis that is caused by what? Rhinosporidium seaberry. And this is what? Aquatic protozoa. And we find the Rhinosporidium seaberry in both the stagnant water and holy dips. They are what? Risk factor. We found where in the stagnant water and holy dips, that is the gathering of the people for that holy dips that we do is what? A risk factor. And the patient will present with what? Nasal polyp. That is the most common presentation. Patient will present with what? This reddish polyploidal polyp. So lesions are what? Polyploidal reddish, and the lesions may be multiple pedunculated and studded with what? White dots. These are nothing but sporangia. These are what? The sporangia. So we get what? We get multiple pedunculated reddish polyploidal polyp with the white studs, and it is highly vascular, which bleeds touch which bleeds on touch. Okay, so very important, we get the reddish pedunculated polyp, and it is highly vascular, so it bleeds on touch. Therefore, on the biopsy what do we get? We get spherules with the endospores. We get the spherules with the endospores. For the treatment, we give out the dapsone and surgical polypectomy. So this is the sporangia. Sporangia spherules containing what? The spores. Sporangiospores containing what? The sporangiospores. Now we'll come to the next. That is what? Sporothrax shanky. We are come to the dimorphifungus sporothic shanky, or the rose gardener's disease. Rose gardener's disease. Rose gardener's disease. The patient will present with what? Nodular ulcerative lesion that is spreading along the lymphatics. Image is very important. We see the nodulosclerotic lesion spreading along the same line, that is along the line of the lymphatics, mainly where? In the extremities. And mainly we see where? In the Himalayan region, and the patient will present with the history of the traumatic inoculation and working in the field, and mainly in the Himalayan region, patient walking barefoot walking mainly in the Himalayan region, and it spreads by what? Thorn pick. In the question, we'll have the history that patient belonging to the person going to the Himalayan region or have the traumatic inoculation and presenting with a nodulo ulcerative lesion along the lymphatics. That is what? Sporothrix shanki or the rose gardener's disease or the rose gardener's disease. And it is what? It is a dimorphic fungus. We saw the all the examples of the dimorphic fungus, that is the yeast and the mold form. Yeast is present at 37 and mold at 25 to 27. Now yeast form will present as cigar shaped yeast cells. We'll see the image, cigar shaped yeast cells, and in the mold we'll get what? Flower like sporulation. Therefore we get what? Flower like sporulation. So this is the cigar shaped asteroids, shaped asteroids, and this is what? A dimorphic fungus. And for the treatment we give what? Itracona. We give what? Itraconazole is the drug of the choice. Cigar-shaped asteroids, flower-like sporulations in the small form, dimorphic fungus, rose gardener's disease, nodular ulcerative lesions along the lymphatics, and patient in the Himalayan region with the barefoot or the thorn inoculation. History of the thorn pick, that is the this rose gardener's disease. Now come to the next dimorphic fungus. Yeah, hi Mulai. This is live session we are taking. So we are done with the rose gardener's disease. Another now we'll come to the another dimorphic fungus, that is what? Histoplasmosis. Now Histoplasma capsulatum is a misnomer because it is not capsulated. It is not capsulated. Only fungus which is capsulated, that is what? Cryptococcus neoformans. Cryptococcus neoformans. Now histoplasmosis, the other name is what? Darling's disease. What is the other name? Other name is what? The Darling's disease, and it is most common endemic mycosis, most common endemic mycosis in the world. It is also known as the Darling's disease, most common endemic mycosis in the world, and it is also known as Ohia's disease, or it is also known as reticuloendotheliasis. Okay, and it is associated with what? Soil enriched with bat or the bird's excreta. So, and it is found along the Mississippi River of the USA. Just remember the other name, that it is the Darling's disease, and it is the most common mycosis, endemic mycosis, also known as the Ohia's disease or reticuloendotheliosis. Now, when we talk about the transmission, it is transmitted by the aerosol transmission of the pigeons or the bats, this excreta. Okay, it is by what? The aerosol transmission and involvement of the lungs, that is what? The pulmonary involvement, causing the pulmonary involvement, and causing the by the hematogenous spread, causing the visceral involvement as well. Now, pulmonary acute to the chronic involvement, and later leading to a visceral involvement and the hepatosplenomegaly. Now, it is also a dimorphic fungus, that is, we are having the yeast form and the mold form, and in the yeast form, we get the narrow based budding yeast cell. What else we need to remember? That it is a tuberculate macroconidia are seen. So important one, that in the mold form we see the tuberculoid macronodule, that is the tuberculate macroconidia are seen. that is where in the histoplasma capsulatum. Therefore, it mimics what TB in the presentation. So, what are the important key points that we need to remember? That other name is the Darling's disease or the Ohia's disease or the reticuloendotheliosis, and it is the most common endemic mycosis. Soil enriched with the bats or the pigeons excreta, therefore aerosol transmission, and we get the pulmonary manifestations and mimics the TB. Very important, it mimics the TB in the clinical presentation due to the tuberculoid macrocornutia that is seen causing that is involvement of the pulmonary involvement similar to that of the mimicking the TB. Now moving to next this dimorphic fungus and causing the systemic infection. Another one that is we'll read about the blastomycosis. And what is the other name of the blastomycosis? This is the North American disease, or it is also known as the Gilt Christ disease, or it is also known as the Chicago disease. Okay, so we'll talk now about the blastomycosis or the Chicago disease or the Gilt Christ disease or the North American disease, and it is caused by what? Again, the fungus, that is the blastomycosis dermatitis. And very important to remember that yeast-like form, it forms the budding appearance, that is giving the appearance of eight appearance. That is the figure of eight appearance. How to remember this? This is how we write B. This is how we write A. So, but A का जो second part of बड़ा है, that is the figure of eight appearance with broad base. With what? The broad base. Okay, that is what it is, the budding yeast cell with the broad base, that is the giving the appearance of the figure of eight. And this is the same, that is the figure of eight appearance with broad base is what? Blastomycosis. What? Blastomycosis. So this is the blastomycosis. There's blastomycosis dermatitis in the yeast form, figure of eight appearance you can see. This is the SD agar, that is the growth in the SD agar. Now, coming to the next one. Next one we'll see now after the blastomycosis. We'll talk about now the coccidiomycosis. Coccidiomycosis is again a dimorphic fungus and caused by the coccidioids, emetis, and it is used as a bioterrorism agent. It also has what? Both mold and the yeast form. Okay, because it is what? Again a dimorphic fungus. Is again a dimorphic fungus. Please remember, it is used as a bioterrorism agent. Next we have paracoccidiomycosis, that is also known as the South American disease. What was the North American disease? It was the blastomycosis. That was the North American was the blastomycosis. In the South, we have paracoccidiomycosis. And other name, that is the what? Lutz mycosis. Okay, paracoccidiomycosis, South American disease or the Lutz mycosis, and it is caused by again paracoccidio brasilensis. What we need to remember, that one is that is South American disease or the Lutz mycosis, and involvement of the lung, we see the pulmonary involvement, and very important, yeast form. Yeast form we get what? Mickey Mouse appearance. The budding yeast form similar to that of the Mickey Mouse appearance, or the wheel appearance, captain wheel appearance, or the mariner's mariner's wheel appearance. Okay, so very important. That first, the coccidiomycosis, that is used a bioterrorism agent, paracoccidiomycosis of the South American of the Lutz mycosis, and Mickey Mouse appearance of the captain wheel or the mariner's appearance. You can see the Mickey Mouse appearance. The budding is showing the Mickey Mouse appearance or the cart wheel like appearance. The cart wheel like appearance or the mariner's appearance or the mariner's appearance. Now this is the shaped barrel-shaped arthrospore that is found where in the coccidiomycosis. Coccidiomycosis is also known as desert rheumatism. Okay? Desert rheumatism as well. And it was used as what? Bioterrorism agent. Okay, so we'll come to the next, to the another time of a fungal infection, that is penicillosis, that is caused by the penicillin marfini. Penicillosis caused by the penicillin marfini, and it is common amongst the HIV patient, opportunistic infection, and produces very important brick red, brick red color pigment. Brick red color pigment and brush conidial arrangement. Two important points to remember, that penicillosis, penicillin marfini, is again a dime of a fungus and producing the brick red color and the brush color arrangement. Chalo, now we'll talk about Candida. Now we'll talk about now we'll talk about Candida. Now we'll talk about the Candida. So, Candida. So we'll talk about the Candida. Now, Candida, what we need to remember, that it is the most important agent is what Candida albicans, that is responsible for the most of the infections from the Candida, and it is an opportunistic fungal infection, and responsible to cause the candidiasis in the HIV and even in the non-HIV. In the patients with the neutropenia, and it is a yeast-like fungus. It is a yeast-like fungus with the pseudohyphae. The pseudohyphae. Okay. Now we have the Candida albicans. We have the Candida albicans. That is the most common clinical. Was the most common clinical isolate. Then we have the Candida dubliensis, that is similar to that of the Candida albicans, and we often tend to confuse with the Candida albicans. Then we have the Candida galpreta, that is the having no pseudo hyphae. And then we have Candida C, that is the most resistant Candida. Now, talking about the normal flora of the Candida, they are normal flora of the skin, the oral cavity, of the GIT, of the vagina, and most infections are therefore most infections are what? Endogenous infections, because they are the normal flora, because they are normal flora, therefore most of the infections in the Candida, they are what? Endogenous infections. Risk factors, we have already seen: person with the HIV or the long hospital stay, or having the long steroid therapy, or even the pregnancy, in the diabetes, having the oral contrast on the oral contraceptives, prolonged antibiotic therapies. These are all the risk factors for the Candida. Now, disease it mainly causes. What are the disease that mainly causes? The disease are mainly caused by the Candida albicans. That is a most important clinical isolate, and we get what? In the Candida albicans, it shows what? The Raynaud broad phenomena, Raynaud broad phenomena, and the chlamydia, chlamydospores formation on what? Corn meal agar. Corn meal agar. Okay. So we'll see the Reynolds broad phenomena image and the chlamydospores formation on the corn meal agar. Now, Reynolds broad phenomena, that shows the germ tube formation, and on the corn meal agar we get what? The chlamydospores, they are formed because it is what? A nutrient. It is a nutrient deficient media, and at 20 degrees Celsius we get what? Chlamydospores. Now, talking about the disease that are caused. Talking about the disease that are caused by it, one is oral thrush. Most common is what? Oral thrush. Then we have esophageal, candidiasis. Then we have vaginal candidiasis with white, curdy discharge. We have candiduria, that is candida, yeast like cells in where? In the urine. Then we have candidemia, that is again in the blood. We have onychomycosis, that is nail falls are involved, and meningitis, mainly in the neutropenic patient, and chronic mucocutaneous candidiasis, mainly in the T cell deficient patient. So oral thrush, most common oral thrush. Then we have esophageal candidiasis, vaginal candidiasis in the urea, in the blood, in the nail forms, meningitis mainly in the neutropenic patients, and the chronic mucocutaneous candidiasis. Now, how do we do the diagnosis? How do we do the diagnosis? Now, first on the SDA we get what? We get the creamy colonies. Okay, on the SDA we get what? The creamy colonies, and we do the PCR for the Candida, sugar fermentation test, and what else? Sugar assimilation test. Germ tube test we have already seen for the Candida albicans, and under the gram stain we see what? We see the E and the pseudo hyphae. And on the SD, we already see the creamy of white colonies, and we do the germ tube test for the Candida albicans. Now, germ tube test is positive for both the Candida albicans and the dubulensis. Now, chlamydiospores on the corn meal agar or the rice meal agar that we have seen, that is present only for the Candida. Growth at 45 degree, that is positive for the Candida albicans, but is not present for the dubulensis. Now, how to differentiate whether it is Candida albicans or the dubulensis? Because the germ tube test is positive for both, and they both shows the chlamydospores on the corn meal agar or the rice meal agar. But when we talk about the growth at 45 degree, it is positive. It is positive only for the albicans, only for the albicans. Now, coming to the next fungus. So coming to the next fungus. Now, this is the germ tube test or the Reynolds blot test that we have seen. That is a culture of the Candida treated with the normal serum and incubated. And the chlamydospore formation, that is formation of large fractal thick walled chlamydospores for the Candida albicans as well as the dubulensis. Now, Candida albicans Reynolds blot phenomena or the lady hand appearance, lady hand mirror appearance, that is the formation of the germ tube. This is the oral thrush, most common candidiasis. Okay, now we'll come to the next opportunistic fungus, that is the Cryptococcus. That is what the Cryptococcus neoformans. Now, Cryptococcus neoformans is what? It is a true yeast. It is a true yeast. Okay, and what else we need to remember, that it crosses the blood brain barrier. It crosses the blood brain barrier. We have two types of cryptococcus. One is the cryptococcus neoformans, that is the pathogenic one, as another is the non-pathogenic cryptococcus. So we have cryptococcus. In the cryptococcus we have two types of cryptococcus. One is the pathogenic and the non-pathogenic. So the Cryptococcus neoformans is the pathogenic one, and it has the ability to grow at 37 degrees Celsius. It doesn't has, and it is phenol oxidase positive. It is not, and the mouse pathogenicity test is what? Positive here. This is not. So Cryptococcus neoformans, that is the true yeast, and it crosses the blood-brain barrier. Pathogenic 37 degrees Celsius, phenol oxidase test positive, and mouse pathogenicity test is what? Positive. Now when we talk about the Cryptococcus neoformans, this is what? Very important. It is what? Capsulated fungus. Very important. It is what? Capsulated fungus, and divided into the four serotypes. Divided into four serotypes. That is the A, B, and D on the basis of the capsular. On the basis of the capsular antigen, it is divided into the four types. Now, Cryptococcus neoformans, that is the capsulated fungus, and divided into the further serotypes on the basis of the antigens. Now, Cryptococcus neoformans and the Cryptococcus cuttati. We need to remember some important difference, that neoformans is what? Worldwide. worldwide reported, and it is mainly in the tropical as well as non-tropical, this subtropical areas. Disease is seen only in the immunodeficient person, in the neoformans. In the gutty, we see the in the immunodeficient as well, plus immunocompetent as well. And it is associated with the soil enriched with the pigeon's excreta droppings, and it is associated with the soil that is around the eucalyptus tree. Okay? It is sensitive to antifungals. It is more difficult to treat. It is difficult to treat. So Cryptococcus neoformans, that is the worldwide and mainly in the immunodeficient, and with the pigeons dropping, it is associated with the soil that is enriched with the pigeons dropping. Cryptococcus neoformans, that is one we already saw, that is the capsulated. Another is that it is present in the pigeons feces or the droppings, therefore responsible for the aerosol transmission, therefore responsible for what the aerosol transmission, which to the hematogenous first will involve through the aerosol lung involvement, and then the hematogenous route will spread to what meninges, because we saw that it causes what the blood brain barrier, and this is known as neurotropism, that is positive for the HIV patient. So present in the pigeons dropping through the aerosol inhaled in the lung, and through the lung it reaches up to the brain, and it is known as the neurotropism in case of the HIV patient. It is therefore most common cause of meningitis in HIV patient. Most common cause of the meningitis in HIV patient, that is the Cryptococcus neoformans. Cryptococcus neoformans. Virulence factor we have already seen. Virulence factor 1 is the capsule itself because it is capsulated. Another, it is ability to grow at the 37 degrees Celsius. Alright, and the having the phospholipase and the urease activity. Now, disease we have already seen, that is through the inhalation, through the lung, through the hematogenous spreads causing the meninges and causing the acute and the chronic meningitis, and the most common responsible for the meningitis in the HIV patient. Now we'll come to the diagnosis. We'll come to the diagnosis that are very important for the Cryptococcus. We'll take the CSF sample. We take the CSF sample, and what stain we use? India ink stain. India ink stain, or the negative stain, or the nigrosin stain. And what we get? Against the dark black background, we get the Cryptococcus capsule. This is to detect the capsule for the Cryptococcus. Other than this, what else we can do? It is a fungus, and the culture on the SDA. Culture on the SDA, we get what? Mucoids. Culture on the SDA, we get what? Mucoid colonies. Mucoid colonies. And on the Niger seed agar or bird seed agar, we get what? We get the black brown colonies. We get what? Black brown colonies. We get what? Black brown colonies containing what? The agar containing what? The caffeine acid, caffeic acid, which is the caffeic acid, and the black colored colonies are due to the melanin production. Therefore, if you remember the we use the for the melanin protection. We use the Fontana Mason stain, if you remember, for the melanin of the Cryptococcus. So first we did the in the CSF sample, we did the India ink preparation or the negative stain or the Negrosin stain against the dark background. We are getting the refractile Cryptococcus capsule. Culture on the SDA, we get the mucoid colonies, and on the Niger seed agar, the bird seed agar, we get the black brown chocolate colonies, and it is due to the melanin production by the Cryptococcus. Now another we test we already did, that is what they are, what urease urease test is positive, mouse pathogenicity test is positive, urease and the 5-phospholipase test that is positive for the Cryptococcus neoformans. Other than this, we do a latex card agglutination test. Latex card agglutination test for the cryptococcal antigen. We'll see the test, the image, we'll see the test, and PCR for the Cryptococcus neoform. We'll come to the drug of the choice, that is what very important, amphotericin B with flucystoside. That is the flucystoside, that is the drug of the choice, and even followed by the fluconazole for the lifelong treatment, for the lifelong prophylaxis or for the 5 weeks. So amphotericin B and the flucystoside. Now will come. This is what, this is the India ink preparation. This is the India ink preparation stain or the Negrosin stain or the Negrosin stain or the India ink preparation, Negrosin stain or the negative stain. And we see what we see the capsulated Cryptococcus neoformans against the dark background. This is the SDA agar. This is the SDA agar, and we are seeing what mucoid colonies. We are seeing the mucoid colonies on the SDA agar, and this is again the for the capsulated and the cryptococcal antigen test. Now, we'll first come to the pneumocystic. Okay, but before that, we need to cover. That was the crushed ping pong appearance of the pneumocystic. We'll cover that, but before that, come to the zygomycosis. We'll read about the zygomycosis. Now, zygomycosis, they are mainly saprophytes and they are also known as the bread mold. They are also known as the bread mold. And risk factors include the metabolic acidosis, diabetic ketoacidosis, or any transplant, that organ transplant has been done, and an immunodeficient person, be it the but remember, in the immunodeficient, HIV is not a risk factor for the zygomycetes. for the zygomycetes. Most common presentation is the rhinocerebral. Most common presentation is the rhinocerebral zygomycetes, that is zygomycosis, and is also known as mucormycosis. So zygomycetes, it is also known as the bread mold, and risk factors are the metabolic acidosis and the transplant recipient patients and the immunodeficient, but HIV is not a risk factor. The most common presentation is the is the rhinocerebral zygomycosis or the mucormycosis that is caused by the rhizopus species and cause the fulminant disease. And we do the tissue biopsy and the H&E staining, and on the SD growth on the tissue biopsy we get what? We get aseptate hyphae with what? Obtuse angle. Okay, so we get what? Aseptate hyphae with obtuse angle. So remember, for the zygomycetes, the most common presentation is rhinocerebral zygomycosis or the mucormycosis, and it is a fulminant condition with aseptate hyphae, very important, at obtuse angle. At what? Obtuse angle. On the SDA, we get what? LPCB mount, that is what? Lactophenol cotton blue mount. Okay, so we get what? LPCB mount, that is what? Lactophenol cotton blue mount. And what is the drug of the choice? That is the phenoconazole. And surgical resection with amphotericin B. Most important here, remember, one is the obtuse angle. Most common presentation is rhinocerebral zygomycosis, and it is a fulminant condition. It is also known as the bread mold, and HIV is not a risk factor. On the SD, we get the LPCB count. Now, coming to the next one is the Aspergillus. The next opportunistic mycosis, that is what? Aspergillus, and we have the hyaline septate with the conidia. Now it is seen, Aspergillus is seen in the patient that are on the glucocorticoids, or the profound, very important, neutropenia. neutropenia. So we have the aspergillosis type, that is allergic bronchopulmonary aspergillosis. We have the superficial aspergillosis involved causing the corneal ulcer, and we have the invasive aspergillosis that is mainly seen and in the colonization of the preformed pulmonary cavity. What is the most important risk factor is the neutropenic patient. And what is the most common species that is responsible is what? Fumigators, Aspergillus fumigatus. Okay, neutropenic patient and the Aspergillus fumigatus. On the diagnosis, we do the lung biopsy and it shows what? Dichotomous branching, and at what? Very important, acute angle. At what? Acute angle. Dichotomous branching at the acute angle. And the superficial aspergillosis involving what? The paranasal sinus, and it is aspergillus flavus, and automycosis. What is the most common aspergillus? Aspergillus niger. So nail for Niger, automycosis, paranasal sinus for the flavors, and the most common aspergillosis species that is causing the infection is what? Fumigators. Fumigator is responsible for causing the allergic bronchopulmonary Aspergillosis. Now, onychomycosis we see that is the Aspergillus niger, and it causes the black crust. It causes the black crust. And most common is what? Aspergillus fumigatus, that is causing the allergic bronchopulmonary aspergillosis, and in where we see the aspergilloma or the fungal ball, and it also causes the automycosis, but the most common agent is what? Aspergillus niger. Flavors we have seen, that is the aspergillus flavors, that is the paranasal sinus, and flavor is also producing a toxin that we need to remember. Flavors, that is the alpha toxin. The alpha toxin. All these are important ones, that dichotomous branching and the flavors causing the alpha toxin, involvement of the paranasal sinus, automycosis, most common niger, and we see what the black crust and the fumigators, ABPA, automycosis, and other pulmonary aspergilloma, that is the aspergilloma fungal ball. Now, we've already seen the lab diagnosis, that is very important. The lab diagnosis, that is what? Dichotomous branching. Dichotomous branching with what? With acute angle. Okay, with what? With the acute angle. In the Rhizopus mucor, we saw the obtuse angle, and here we see what? Acute angle. Now, coming to the next one, just one or two fungus are left, then we'll end the session. We'll come now to the Pneumocystis cerevisiae. We'll see what the Pneumocystis cerevisiae, that is. It is mainly considered as protozoa because it is having the cyst and the trophozoite form. But it is due to the chromosomal studies similar to that of what? Studies similar to that of what the fungus is considered as the sometimes as the fungus. So it is both considered to be protozoa and the fungus due to the cyst and the trophozoite, and also it doesn't have the ergosterol in the cell membrane that the fungus have. But due to the chromosomal studies, it is classified under what? The fungus. So if both are given in the option, we'll go for the fungus. Now, etiological reservoir of the pneumocystic cerevisiae is not known, and the infections occurs by the inhalational route, and mainly in the patients with the HIV, with the malnourished patient, or the COPD, or the long-term steroids. That is an opportunistic infection. And what is the disease that we get? Is what? Pneumocystic pneumonia. The pneumocystic cerevisiae pneumonia, that is what? That is a bilateral interstitial pneumonia starting from the peribulbar region. Clinical symptoms, clinical features will include the dry cough and dyspnea. Pneumocystic pneumonia, that is a bilateral interstitial pneumonia causing the dry cough and the dyspnea. One, we have the pneumocystis carni pneumonia, that is mainly in the patients with the CD4 counts less than 200 in the HIV positive patient, HIV positive patient. And what is the drug of the choice is given for the cotrimoxazole. Cotrimoxazole is the drug of the choice. We give what? For the pneumocystic Girovasi or pneumocystic carni. So that is the we see the interstitial pneumonia with the dry cough and dyspnea, and the CD4 counts are less than 200, and the HIV positive patient for the pneumocystic girovasi or pneumocystic carni pneumonia. Coming to the lab diagnosis, that is bilateral broncho involvement of the bilateral interstitial pneumonia and bronchoalveolar lavage. We take the BAL, that is the bronchoalveolar lavage fluid, and the gastric washings in case of the children. Why? Because they inhale the sputum, ingest the sputum. Sorry. So that is the gastric washings in case of the children. And we stain with GMS, that is the Gomoris methamine stain, and we get what? We get the trophozoite and the cystiform. Trophozoite as the green and the cystiform as the black. Since it is not a typical fungus, it is not cultured on the SDA. It is not cultured on the SDA. Treatment of choice we have already seen. It is what? Cotrimoxazole. This cotrimoxazole. Okay. So for the lab diagnosis, we take the bronchoalveolar lavage fluid and the gastric washings in case of the children, because they ingest what? They ingest the sputum. Now GMS stain that we do, that is trophozoite, we get the green color, and the cyst we get what? The black color. So this is the pink ball appearance. This is the crushed pink ball appearance, and we see where in the GMS stain, because just we read about in the GMS or the Gomoris methamine stain, we see what the green colored, we see the green colored trophozoite form and the cyst as the black color. Now, so we are done with the session now. We are done with the fungus. We have covered the fungus in a fast mode. All the important points were covered about the fungus. We covered the fungal infection and all the superficial, deep, and the systemic mycosis along with opportunistic mycosis. And please do use my code, that is Muskan 10, to get 10% off. And thank you for this session. We'll see you soon, and we'll cover the next topic. So do press the bell icon and like, share, and subscribe the channel, and use my code, that is Muskan 10, to get 10% of the discount. So I hope all the important images were covered along with the fungus, and all the important points were covered. One thing I didn't tell you, that for the aspergillosis, the drug of the choice is voriconazole. For the aspergillosis. All right, all the important images were included, and thank you. So take care and bye bye. Yes, next session will be tomorrow itself on the 10 a.m. only, and we'll cover. Just check. Let me check the time. It's 9 November. Yes, yes. Tomorrow session is at the same time. That is the 10 a.m. and we'll cover the general bacteriology in the fast mode along with the images from the general bacteriology, just like we did today. So thank you. I will see you tomorrow at the same time. Until that, take care and bye bye. All right. Take care.